anal fissure is a tear in the lining of the anus, the opening where feces are excreted. The tear typically extends into a circular ring of muscle called the internal anal sphincter. The fissure is described as acute if it has been present for less than 6 weeks, or chronic if present for greater than 6 weeks. Once a fissure develops, the internal anal sphincter typically goes into spasm, causing further separation of the tear, constricting blood flow to the area, and impairing healing and causing pain. What symptoms will you experience with an anal fissure? Patients with an anal fissure may first note bleeding and a sensation of tearing, ripping, or burning following a bowel movement. Once a fissure develops, these symptoms can occur after every bowel movement. The rectal pain can be severe and can last several minutes to hours after the bowel movement. Bleeding is usually of small volume, though it often is bright red. However, the bleeding may discolor the toilet bowl, giving the appearance of heavy bleeding. Some patients also note itching or irritation of the skin around the anus. Who gets anal fissures? Anal fissures are usually caused by trauma that stretches the anal canal, such as after passage of large or hard bowel movements or severe diarrhea. Less commonly, fissures are caused by foreign body insertion or anal intercourse. Anal fissures can also occur in patients who have other medical conditions such as Crohn's disease, an inflammatory bowel disease of the intestines. How do we diagnose an anal fissure? Anal fissures usually can be diagnosed based on symptoms described and on physical examination. The physical examination involves gently separating the buttocks, allowing for visualization of the entire anal region, and a fissure most commonly appears in the 12 and 6 o'clock position. Fissures located in other locations are more likely to be associated with an underlying disorder, such as Crohn's disease. A rectal examination involving insertion of a gloved finger into the anus, or anoscopy, insertion of a small instrument to view the anal canal, can often be avoided in initial diagnosis of a fissure. These examinations can cause increased pain and are often unnecessary to establish a provisional diagnosis based on history and visual examination. Further evaluation may be required if there is concern that another medical condition may have contributed to the development of the fissure. If the diagnosis is unclear, a colonoscopy is usually recommended, especially if there has been rectal bleeding. How do we treat an anal fissure? Medical and surgical treatments are aimed at reducing the tone of the internal anal sphincter muscle, leading to pain relief and healing of the anal fissure. People with a new anal fissure may resolve this without medical treatment, though higher cure rate is associated with treatment by a physician. By contrast, with a chronic anal fissure, usually requires medical intervention initially, and treatment involves medical and is aimed at limiting constipation, softening stools, and reducing anal sphincter spasm. There are several approaches to reducing anal sphincter spasms. These measures are successful in approximately 75% of patients. However, some patients may not heal, or they may develop frequent recurrences. Such patients may require surgery, which is successful greater than 95% of the time. Avoiding hard bowel movements will prevent trauma to the anal canal, promoting healing of the fissure. Increasing fiber in the diet is one of the best ways to soften and bulk the stool. Fiber is found in fruits and vegetables. The recommended amount of dietary fiber is 20 to 35 grams per day. Fiber supplements are usually commercially available, including psyllium with metamucil and wheat dextrin with benefiber. These products work by absorbing water and increasing stool bulk, which improves the regularity of bowel movements while softening stools. A variety of drugs and natural products are available for treating constipation. Polyethylene glycol, or PEG, 70 grams per day, brand name is Laxative, is a recommended laxative. People are often concerned about the regular use of laxatives, fearing that they will not be able to have regular bowel movements afterwards, after stopping the laxative. However, with the exception of the cathartic laxatives, such as senna-related products, there is little to no evidence that laxatives increase the risk of constipation in the future. Topical nifedipine. This works by reducing the internal anal sphincter pressure. Nifedipine is used for fissure treatment when compounded into a topical treatment and applied directly to the perianal skin. Topical treatments with 0.2% nifedipine 3 times per day has few side effects. Botulinum toxin is a neurotoxin produced by bacteria. It temporarily paralyzes the muscles for up to 3 months, and it can be injected into the internal anal sphincter muscle in a clinician's office without anesthesia or sedation. The dose is extremely low and has virtually no risk of causing any poisoning. Botulinum can cause temporary mild anal incontinence, which is leakage of gas or stool, in some patients, about 5%. Because it involves an injection rather than topical application, it is usually reserved for patients who do not respond to the topical therapy. Surgical procedures are generally reserved for people with symptoms that have persisted despite medical therapy for at least 3 months. The procedure of choice is called a lateral internal sphincterotomy, which relaxes the internal sphincter by cutting this muscle. This is generally performed as an outpatient procedure while providing the patient a general anesthetic. Pain from the sphincterotomy is usually mild and is often less than the pain of the fissure itself. Patients often return to normal activity within 1 week. The main concern with surgery is the development of fecal incontinence. Fecal incontinence can include the inability to control gas and/or stool. Mild incontinence in the form of anal seepage can occur in up to a third of patients in the immediate postoperative period, and this may be mistaken by patients for permanent incontinence. However, this immediate post-surgical incontinence is rarely permanent and is usually mild. The risk of permanent incontinence is less than 1%.